right. So, how do you approach compound EGFR mutation? So we know that EGFR mutations, exon 19 or L858R, are common. But Dr. Preeshagul, what if you see a compound mutation? Let's say, exon 19 and something else like, G719. And how common are these? Do you see these in practice? I think you're muted.
Wow.
Don't worry. Dr. Preeshagul and I do this all the time. This is our first time on this platform, so we both apologize for the technical glitches.
Oh my God. It's actually my second, which is so embarrassing. So I should know better. Anyways, as I was saying, if you can't read lips, I love this question, Dr. Sabari. And I love it because there's no right answer. Um, I think the more you look, the more you're going to find, right? So, and also the more you find, the more you have to look up and read about and teach. So, compound alterations, I don't think we know the right thing to do with these patients yet. Unfortunately, there's no right answer. I can't tell you how many times I see something like this and I'm like, EGFR, 6, 7, whatever, all of this. And I'm on PubMed, I'm on UpToDate, I'm on, did anybody else have any experience with this? Because if I don't, you have to phone a friend, you have to ask somebody. And if there is no literature, there is no data out there, I have to go with standard of care for these patients.
Yeah, I agree. I think these compound mutations are difficult and to manage, and we know that the prognosis for patients with compound mutations is not as great as those who have single alterations due to the complexity of the tumor. And I think enrolling on a clinical trial here is critical. Another question, Dr. Preeshagul, here is about T790M, and maybe explain that to us. Does that happen up front? And maybe there are some rare cases of that genetically inherited, or is that something more common that happens at resistance? And how do you think about that? And are you still seeing that in your practice?
Sure. So T790M is a gatekeeper resistance alteration that typically develops after you have progressed on, a second generation tyrosine kinase inhibitor like erlotinib or gefitinib. We're not really seeing T790M as much now because we're not really looking for it. And osimertinib is the drug that really came about first because it showed activity against patients that harbored the T790M alteration. So I can't say I'm looking for this because before we had osimertinib, if we saw that someone was progressing on erlotinib or gefitinib, we would say, oh, let's look for this T790M resistance alteration, and then we can give them OC. So now that we have osimertinib approved in the frontline setting, we're not really seeing this, but we do see it from time to time. And I actually have seen some germline T790M alterations in patients that we're seeing more and more about. So I wouldn't say it's very common to look for this, but I do come across it. But it doesn't really excite me that much. It doesn't really change my practice as of now.
Yeah, I would agree.